Thank you very much for the very generous and very long introduction. I'm going to start by a video because I think a video will sort of tell the CKD story a little bit and set the stage for the problem before I start to present two different approaches for a solution. So let's play the video.
Chronic kidney disease, or CKD, is a condition where your kidneys gradually lose function over time. The two main causes of CKD are diabetes and hypertension, which are responsible for up to 2/3 of all cases. Immune and inherited causes and other reasons are responsible for the rest. 10% of North Americans, or approximately 26 million people, experience some form of CKD, and more than 25% of people over the age of 65 have CKD. The good news is only 3% of all CKD patients ever experience kidney failure requiring dialysis or transplant. Your kidney's primary function is to filter and excrete waste products. To find out how well your kidneys are doing, we measure the quantity of waste that circulates in your blood. This is called glomerular filtration rate, or GFR. The more waste products in your blood, the lower the filtration rate, or GFR, of your kidneys. GFR is divided into the 5 stages of CKD. In stage 1, there is no or slight deficiency in kidney function. Stage 2 indicates a mild deficiency. Stage 3 is moderate. In stage 4, there is a severe decrease in kidney function. And stage 5 is approaching kidney failure. We've developed the kidney failure risk equation to determine the probability of kidney failure for CKD patients in stages 3 to 5. The equation uses your age, gender, GFR, and urine albumin to give an accurate representation of your kidney's risk of failure in the next 2 to 5 years. You don't have to be in the dark about the health of your kidneys. If you're concerned about the health of your kidneys, talk to your doctor and go to kidneyfailurerisk.com for more information.
So now that you've heard a little bit about CKD, let's get to my talk. What I'm going to talk today about is medicine and big data. So two sort of big important topics in our society and how they converge in answering challenges, creating opportunities, and I'm going to show you a potential success. So the clinical problem that I'm going to talk about as a kidney doctor is chronic kidney disease, or CKD. As you heard, it's a major public health problem. It affects 1 in 10 Canadian adults and more than a quarter of those over 65. It can lead to kidney failure requiring dialysis, which really has devastating consequences for people. Patients on dialysis spend 3 days a week in the hospital, about 6 hours a day, so 18 hours of their week every week is gone, and they have a survival that's worse than a lot of advanced cancers. In addition to this dialysis, kidney disease leads to loss of productivity for younger patients, loss of employment, quality of life, and early premature death. So it really is a global and major problem. Here's the specific problem within kidney disease that we wanted to tackle. The prevalence of kidney disease, or how common it is rising worldwide. If you look at this map right here on this side, assuming a population of 6.6 billion, there's probably 200 to 350 million people in the world that have moderate to severe chronic kidney disease. That's a lot of people. And as you can see, it's spread all over the world virtually. While there are 200 to 350 million people who have this advanced kidney disease, there's only about 2.5 million who are on dialysis. And even if you look at countries like Canada and Western Europe, only 3% of people with this type of kidney disease end up on dialysis. So the problem is that we have a really wide funnel at the top of all the people who have chronic kidney disease, and we have a really narrow funnel at the bottom where only 3% of them are ever going to experience kidney failure. We need to identify the people who are going to have kidney failure and treat them differently and aggressively. And we need to identify the people whose kidneys are never going to fail and treat them conservatively with reassurance, peace of mind, and minimal medical intervention. So what are the approaches to this? Well, we think the approaches to this all lie in big data. And even within big data, there's 2 types of big data that I'm going to talk about. The first type of big data that is what people sometimes associate health with. And this type is related to physiology, and it's the omics approach. Many of you may have heard of omics. Omics as in genomics, proteomics, or metabolomics. So genomics is the study of the human genome or human genes. This is under the assumption that a lot of disease is inherited and that genes, or in the study of genes, can really help identify who's at risk, who's going to have disease. Then there's proteomics. Proteomics is the study of the proteins in our blood. So most of the genes that we carry make proteins, and proteomics looks at the blood, looks at the urine, tries to identify proteins that are associated with disease, and says that perhaps there's a protein signature out there that can predict who's going to have disease and who's going to stay healthy. And then there's metabolomics. Metabolomics looks at pieces of proteins or metabolic pathways, so how proteins are broken down, how proteins are synthesized, and looks for signatures. Perhaps it's not the proteins or the genes, perhaps it's the metabolome or the signals in these pathways that can unlock the key for disease and not diseased. We use a different type of big data. So that's the one type. That's the wet lab, the beaker, the test tube, the big lab approach to big data. This is our lab's approach to big data, the dry lab. This is big data from informatics. This is big data from wearable technology. Data from your Fitbit that tells me how many steps you took, how long you slept, how many times you got up at night, what was your heart rate when you were running, what was your heart rate when you were sleeping. From the electronic health record, from when you went into the hospital, every single measurement that you had when you went to the hospital, every blood test, every urine quantity, everything that was recorded, every doctor's communication, that's part of big data in the electronic health record. There's the laboratory information system. Every lab test that you ever have is recorded in a laboratory information system. Diagnostic Services in Manitoba, for example, has 70% of the data in this province. Another lab called Gamma Dynacare has 25% of the data. There's administrative databases, which you may or may not know about, but Manitoba Health has perhaps the richest and largest repository of administrative databases, where I can identify every encounter an individual person has with the healthcare system. Every time you see a doctor, every time they register a code, they make a prescription, you get admitted to a hospital, every single one of those encounters is logged in these administrative databases. And we can link all of these pieces of big data together to generate a profile of a person, de-identified, of course. All of these things get scrambled and de-identified, but we have unique individuals, and we have a rich set of data on each of these unique individuals. Another frontier, which is yet untapped, are the large commercial data sets. Think about the data set at Shoppers Drug Mart and the Superstore, which has your shopping patterns, what you buy. Do you eat healthy? Do you eat unhealthy? When do you eat healthy? What are your over-the-counter drugs? So again, there's another example of a whole different type of big data, not the omics, not the proteomics, not the metabolomics, but the informatics. So the data that you generate in your environment as you interact with it. So the problem is who goes on to dialysis. A lot of people with kidney disease, very few onto dialysis. And I'm going to show you what happens when you take an omics approach to it and what happens when you take an informatics approach to it. So let's start with the omics. So from genomics, there's been multiple genome-wide association studies. So many of you may remember or recall the Human Genome Project. It mapped out the entire genome for humans and had an incredible amount of promise to identify genes or SNPs, which are called single nucleotide polymorphisms. So gene changes that are common to individuals that can perhaps explain chronic disease. So many, many genes were identified that link with chronic kidney disease. Some of them include a gene called UMOD, which codes a common protein in the kidney, a gene called ApoL1, which codes a very neat protein, which actually protects against sleeping sickness in Africa, but also explains why Africans have a higher prevalence of kidney disease. So this is a really neat example of Mendelian evolution, where a gene that protects against sleeping sickness got propagated even though it causes kidney disease. Sadly, if you look at all the genes combined, they only explain 2% of the heritability in kidney function. So every single gene we've identified to date only explains 2% of the change in kidney function. UMOD increases your risk by 20% But if you think the average person with kidney disease has a dialysis risk of 3%, so maybe it takes you from 3 to 3.6. It's not a quantum leap. ApoL1's really interesting. It increases your risk by twofold, but it only explains the risk in people of West African descent. So yes, it helps unlock a mystery in a certain ethnic group, but it really doesn't get to the other 95% of people with chronic kidney disease. So genomics has sort of left us here. When you take all the genomic signals together and you try to see, do they add anything on top of clinical data, the results remain equally disappointing. So this is the Framingham Study people, very famous risk score conductors, and they looked at a clinical risk score using just clinical data that they had on patients sitting in front of them and compared it to a genetic risk score. And this is what they found. These two lines are virtually interchangeable. Believe me, there's two lines there. Those two lines represent the accuracy of the scores. If they were perfectly vertical, that's a perfect score. And if they're totally diagonal, that's a useless score. That's the fit of that's a flip of a coin. So you can see it's somewhere in between diagonal and perfect, but it's no better when you include genetics on top of clinical data. So do proteomics and metabolomics help? Well, there's been multiple studies actually examining the urinary proteome. Several of them actually have been led out of the University of Manitoba. And what they've found is that there's collagen, which is a common protein in the human body. Collagen and its relatives, its related proteins, tend to be associated with early damage in kidney disease. So perhaps they've uncovered a new role for collagen, and one day in 20 or 30 years, that may lead to a therapeutic intervention. But does it help you predict kidney disease now? The problem is now, does it help you answer it? There's actually, metabolomics don't add anything, and somebody did build a classifier. They took 273 proteins and built a model called the CKD273 classifier and looked to see whether that improved prediction. As it turns out, not very much. So on that side, you have the CKD273 score, and here you have urine albumin, which is the most common protein routinely measured in every lab across North America and the world. The two lines aren't that different, so I would challenge to say the CKD273 classifier, which probably is very expensive to do and very impractical to translate in the world, doesn't help you that much beyond urinary protein. So again, genomics, proteomics, and metabolomics generate wonderful hypotheses. They teach you about new pathways which you haven't learned, but they don't necessarily solve the challenges of today. So what about the informatics approach? So the informatics approach uses big data, uses data from electronic health records, from things you wear, from administrative databases, and it tries to get at those same questions. So we use the informatics approach in our work. We used electronic health record data from a hospital called Sunnybrook in Toronto. We used lab information system data from Gamma Dynacare, which was a big lab provider. And we used administrative data initially from Ontario and BC, and we routinely use Manitoba administrative data in our work. Our whole approach was based on this idea of using routinely available data because we wanted our solution to be implementable tomorrow and globally. We wanted to predict the outcome that patients cared about. Patients care about being on dialysis. They don't care about having stage 3 or stage 4 kidney disease. So we wanted to predict the need for dialysis. And we wanted to validate it everywhere. What validation means is that your model that you build in Manitoba or you build in Ontario is accurate in the UK, it's accurate in India, it's accurate in China, it's accurate in Japan. You have to show that. You have to prove to people that this really works. And so we looked at these candidates, we looked at simple blood and urine tests, we looked at simple diseases like diabetes and hypertension, and we verified medications and outcomes using our administrative data links. What we found was we developed 3 models, a 3-variable model, a 4-variable model, and an 8-variable model, which are called the kidney failure risk equations, which you saw in that video. They all used routinely available data, and they were between 84 to 91% accurate for predicting the risk of kidney failure. That little genetic risk score I showed you was 75% accurate. So the informatics approach thoroughly wins out. It actually uses very simple solutions and predicts the outcome of interest to patients, to providers, to the healthcare system with a lot of accuracy. This is what it looks like. So if you're a doctor, you have your iPad, your telephone, you go on the app, and you can figure out the patient's risk in 2 years and in 5 years. So doctors all over the world use this. We track their usage because we made these apps, we made these websites. So we're able to follow exactly what's going on. We're able to refine our aids. We're able to study the patterns of usage. We then went and said, let's show that it's accurate all over the world. We took 12 populations from North America of 617,000 individuals. We went and got 11 participants from all over the world. This is that Maccabi refers to Israel. Okinawa is in Japan. Hunt is in Norway. GCKD is German CKD. In total, we took 721,000 individuals from the world, 30 different countries, and we showed that the kidney failure risk equations are accurate. Here's the measure of accuracy, 90% summary, 0.90 across all 23 cohorts, across 30 countries, 4 continents. And this is a neat little visualization, which is of all 23 cohorts are shown here. Again, as I said, in this case, what actually happens is here, what the equation predicts is here. So the perfect diagonal is perfect prediction. And as you can see, across the 23 cohorts, almost always the prediction is diagonal. Almost always the prediction is right on. But that's the physician piece. What about the patient piece? How do you empower patients? How do you give information about prognosis to patients in a meaningful way? So then we sought out to develop these tools. So this is our patient interactive tool that gets given and discussed at every visit. We start our conversation just like this. We say, your kidney's main job is to filter and excrete waste product. There are 5 stages of kidney disease where kidney function goes from more than 90% all the way down to 15. We tell them that diabetes causes 45% of kidney disease, that high blood pressure causes a quarter, and that they're not alone, that 10% of North Americans have kidney disease, that 25% of them over the age of 65 have kidney disease, and a lot of them are awaiting kidney transplants. We tell them not to worry, because only 3% of patients with kidney disease experience kidney failure. And then we show them that using this equation, which has been proven accurate in 30 countries, their individual risk for this 40-year-old man with 43% GFR is 7% at 2 years and 20% at 5 years. We tell them, this is your risk, this is the plan based on this risk, and this is how we're going to keep this risk low. We engage them in taking charge of their own health care. We help them maintain better control of their blood sugar, better control of their blood pressure, and continue to prevent kidney failure and delay its progression. So to summarize the work, the kidney failure risk equation is simple, highly accurate, and validated across a number of diverse patient population. But its success really lies in its simplicity. It's simple, it's adaptable, it's portable. And global validation, which is what we're squarely focused on, will ensure that its widespread use continues. So we've developed the kidney failure risk equation, and that work just now needs to be implemented. But what do we all do next? What do you do next? What do I do next? I think we continue to integrate health databases with non-health databases. This has never been done. Let's pursue public-private partnerships. Let's work with other public stakeholders like Hydro to look at what about power utilization in health. Let's look at things that are outside the box. Let's look at the electronic health record using natural language processing. So to date, when we look at the electronic medical record, we're only extracting individual variables like your age, your blood pressure, the date you came in for your visit. What we're not doing is mining the free text. Perhaps the doctor is writing, I'm quite worried about this patient, and it's not captured in the tests. But we can mine that using natural language processing. Let's integrate wearable technology into the physician record. Let's find a way for your doctor to be able to access your step count or your wearable blood pressure or your Bluetooth connected scale at home so that when you show up for your physician visit, he or she can see what you've been up to in the 3 or 6 months preceding the visit. Let's combine these data streams to focus on building simple, elegant predictive models, models that can be used globally and that can actually answer big clinical and big public health problems. If we're able to do the first four things, we'll truly bring healthcare to the 21st century. Thank you.